Welcome, future doctors. Let's jump right into a topic that is absolutely guaranteed to pop up on your exams: dermatophytosis. You probably know it better as tinea or even ringworm. We're going to do a super high-yield, no-fluff review here with everything you need to know to just nail this on your boards.
Okay, so here's our roadmap for today. We're going to cover the MET agents, and you'll see what that means in a second. Then we'll look at the different types of tinea, the classic signs to watch out for, how to diagnose it in the lab, and of course, how we treat it. Let's get into it. First things first, let's meet the culprits behind ringworm. So what exactly is dermatophytosis? Well, it's a superficial fungal infection, and the key word here is superficial. These fungi, called dermatophytes, are basically keratin eaters. You know keratin, right? It's that tough protein that makes up our skin, our hair, and our nails. These little guys have special enzymes that let them break it down and use it as food. That's their whole deal, and that's why the infection stays right on the surface. Okay, this is super high yield for your exams, so listen up. There are 3 main genera of these fungi, and all you need to remember is the acronym M-E-T. That's M-E-T. So M is for Microsporum. It infects skin and hair. E is for Epidermophyton. It goes for skin and nails. And T is for Trichophyton. Just think of T as the total package. It infects all 3, skin, hair, and nails. Got it? M-E-T. Perfect.
All right, next up, let's make a clinical map. We're going to look at where these infections actually pop up on the body.
So this table right here, this is pure exam gold. The naming system is actually pretty logical, which is nice for a change, right? It's always tinea plus the Latin name for the body part. So, tinea capitis. Capitis sounds like cap, so that's the scalp. Tinea corporis. Corpus means body. Tinea pedis, pedal for feet. You get the idea. Cruris is the groin, barbae is the beard area, and unguium is the nails. Super straightforward and very, very testable.
And here's what tinea capitis looks like in real life. See that lesion on the scalp? A key sign is those broken off hair shafts. You might even hear about black dot tinea capitis, and that's literally just the hair breaking off right at the surface, leaving little black dots. It's a classic sign.
Now this is what most people picture when they hear ringworm. This is Tinea corporis. And of course, we know there's no worm involved, right? The name just comes from this classic ring-shaped lesion. It forms that perfect circle because the fungus is actively growing and spreading outwards from a central point. And here we have the infamous athlete's foot, or Tinea pedis. The fungus just loves that warm, damp space between the toes, so you're gonna see a lot of peeling and cracking skin right there in those web spaces. Super common, but you've gotta know it when you see it. Okay, section 3. Let's talk about the classic clinical signs. What exactly should you be looking for in a patient? So when you see a suspicious lesion, here's your mental checklist. Is it annular or ring-shaped? Yep. Is it peritic? Meaning, is it itchy and scaly? For sure. Does it have raised edges? This is key. That raised border is where the fungus is most active. And finally, does it have central clearing? As that ring expands outwards, the center often starts to heal. If you can tick off these 4 boxes, you should definitely be thinking ringworm. Moving on to lab diagnosis. This is absolutely critical, especially for your practical exams. You need to know the steps to get from a simple skin scraping to an actual definitive identification. So the workflow is pretty straightforward. Step 1, get your specimen. You're going to take skin scrapings or pluck some hairs. Step 2, do a direct examination with a 10% KOH mount. The potassium hydroxide dissolves all the human cells, leaving just the fungal elements behind so you can see them clearly. Step 3, culture it. You'll use a special medium called SDA and let it grow for about 4 weeks. And finally, step 4, once it's grown, you'll do a microscopic ID, usually with an LPCB mount, to figure out exactly which fungus you're dealing with. Okay, remember our MET friends. This is how you tell them apart under the microscope. It's all about looking at their macroconidia, which are the big spores, and their microconidia, the little ones. The shape and how many there are of each is the dead giveaway. For Trichophyton, think T for thin. The macroconidia are thin, kind of pencil-shaped, and you won't see very many of them. What you will see is an abundance of tiny microconidia. So lots of little guys, very few big, thin ones. That's your Trichophyton. Now look at this, a totally different picture for Microsporum. The mnemonic here is M for massive macroconidia. Look at them.
They're numerous, they're thick-walled, they're spindle-shaped. They are the absolute star of the show. If you see these big, beefy macroconidia, you are looking at Microsporum. And finally, we have Epidermophyton. The trick here is ep for empty. It is empty of microconidia. There are absolutely zero. What you'll see instead are these pretty distinct, smooth, club-shaped macroconidia, usually in clusters. No little guys at all. So if you see those club-shaped macroconidia and no microconidia, it's got to be Epidermophyton. All right, last section. Let's talk about treatment and wrap this whole thing up with some key takeaways. So how do we treat this stuff? Well, for a simple skin infection, you can often get away with topical agents like Whitfield ointment or tolnaftate. But, and this is a big but, if the infection involves the hair or the nails or if it's really widespread, topicals just aren't going to cut it. You have to go with oral drugs. The main drugs of choice are terbinafine and itraconazole. Now, this is a really important point for when you're talking to patients. Treatment duration is not one size fits all. A simple skin lesion might clear up in a week or two. But if it's in the hair, you're looking at 6 weeks of treatment. And for nails, that's onychomycosis, we're talking 3 months. You have to explain this to your patients because if they stop early, it's just going to come right back. Okay, to wrap things up, here's a quick recall question for you. Think back to our MET mnemonic. Which of those 3 agents will you never see causing a hair infection, a Tinea capitis, and why? The clue is right back at the beginning of this explainer. Think about what each one infects. That's a classic exam-style question right there. All right, that's our deep dive into dermatophytosis. I hope this helps you absolutely crush it on your exams. Good luck.